Okay, so let us start again. Okay, if you see this picture, this is basically a picture of my team from Hospital Raja Permaisuri Bainun Ipoh. It was taken basically about 1 year ago. If you look at the picture, they got no physical distancing, no mask, and definitely look cheerful. It seems like an ancient stories now. And next, with the COVID-19, we goes into this new norm of physical distancing, no handshaking, wearing multiple layers of PPE, wearing masks all the time webinars course instead of attending the normal courses like the one that we are doing now. And it's not only affected us as frontliners, but also our loved one, the elderly and small kids. Next. With a national vaccination program that aims to cover 23 million of Malaysians by the end of phase 3, we hope we will slowly develop the herd immunity towards COVID-19. But the question is, are we ready for the complication during the vaccination program? Because everybody was so scared for the side effect of the vaccine, and with the little knowledge we have about this vaccine, it makes the decision more difficult. So maybe we go a little bit about COVID-19 vaccine. What makes it so interesting about this vaccine? It is basically a new types of vaccine, mRNA vaccine, not a live virus vaccine. Never before we have any mRNA vaccine, and this is the first vaccine that only took approximately 11 months to be confirmed that it is effective and safely tolerated. And for your information, previously no new vaccines has been developed in less than 4 years. And the mRNA vaccine does not enter the nucleus of the cell and is degraded quickly. It is therefore biologically and clinically unlikely to pose a risk to the tissue DNA or to pass to the fetus. Right. So this is studies report by JAMA published about 1 week ago. It was done for within a month from December 14, 2020 to January 18, 2021. And out of 10 million doses of Pfizer and 8 million doses of Moderna vaccines that they received, only 66 cases developed anaphylaxis, right? So out of these 66 cases, 30% of the patient who developed anaphylaxis noted to have a prior episodes of anaphylaxis from other exposure. For example, maybe they have exposure, maybe they develop anaphylaxis from vaccines prior to this, or contrast media, or latex or walnuts, right? So all these 66%, 52% were treated in an emergency department and 48% were hospitalized. So including 18 in intensive care, 7 of whom out of these 18 required endotracheal intubation. And 4 out of these 7 patients developed facial, tongue or laryngeal angioedema. And there was no death reported from anaphylaxis after vaccination with either product. If you can see, the symptoms of anaphylaxis basically develop within 10 minutes from the time of injection. And look at the graph here under the Pfizer. You can see it's only 4.7 cases per million doses of vaccines delivered patient develop anaphylaxis, and only 2.5 anaphylaxis reporting rates over per million doses administered. Next. So the number was small, but the incidence of anaphylaxis is real. So if you see the definitions of anaphylaxis, this was taken from the second symposium on the definition management of anaphylaxis by the second National Institute of Allergy and Infectious Disease for Allergy and Anaphylaxis Network Symposium. You can see it's defined as an acute, potentially life-threatening multi-system syndrome caused by the sudden release of mast cell mediators into the systemic circulation, and it results from immunoglobulin E mediated reactions to the allergen. So what's important about anaphylaxis? You need to know it is acute or sudden onset and life-threatening. It can involve multi-system. Next. So how do we want to diagnose anaphylaxis based on this definition? So the diagnostic criteria for anaphylaxis is a little bit difficult. I can't see the next slide. All right. So most of the time, if you read the UK Resuscitation Council, you read the CDC guidelines, they come out with the first criteria of anaphylaxis. But based on these Samson's criteria, which have 95% sensitivity and 71% specificity in diagnosing anaphylaxis, it divides the anaphylaxis into these three criteria. Any one of the criteria, if it's fulfilled, the anaphylaxis is highly likely to occur, right? So number one criteria is basically acute onset of illness, minute to several hours with involvement of the skin, mucosal tissue or both, right? With at least one of the following. Either the patient developed respiratory compromise or the patient developed hypotension or symptoms of an organ dysfunction. For example, syncope or incontinence or hypotonia, right? So number two, if the patient developed two or more of the following, all right, rapidly after the exposure to the likely antigen within minutes to several hours, right? So this patient can be diagnosed as anaphylaxis, all right? You can see the involvement of the skin mucosal tissue, the respiratory involvement, the systemic involvement where the patient comes to you with hypotension or any other end organ dysfunction, and also if the patient comes to you with persistent GI symptoms, right? Number three is basically based on the hypotension itself. So if the patient develop hypotension after the patient exposed to a non-allergen within minutes to hours, either in infants or pediatric or adults, this also can be one of the diagnostic criteria for anaphylaxis. So next, it is a clinical diagnosis. Sometimes the patient presented may not be fulfilled the criteria as mentioned above. For example, in patients who had a history of severe anaphylactic reaction, but this time around come to you or presented to you with only urticaria and pruritus, generalized urticaria and pruritus. So the diagnosis can be very likely in these types of patients and may warrant immediate management. So let us go to the body system involvement. If you look at the second criteria where you have 2 out of 4 body involvement, you have you can also diagnose a patient to have comes to you with respiratory distress, stridor, hoarseness, lump in the throat. This is basically, lump in the throat is one of the common presentation, or they might complain to you with a foreign sensation in the throat, or if they come to you with drooling of saliva, so you need to think, or either this patient develop anaphylaxis or something else, right? So the other symptom, for example, cardiovascular, they might present to you with dizziness, persistent tachycardia, hypotension, low pulse volume. So same goes to nausea, vomiting in GI, and impaired mental status in neurological system. So next. So any 2 of body system involved can lead to the diagnosis of anaphylaxis. So this is the sign and symptoms that can occur within minutes to hours. You can see almost all of the patient comes to you with symptoms of urticaria or angioedema, and also presented with pharyngeal and laryngeal edema. And about 30% of patients presented with GI symptoms, hypotension, and a very minority of patients presented to you with neurological deficit, pruritus, or stridor. But bear in mind, as I mentioned, based on the class 2 diagnostic criteria for anaphylaxis, they will presented with 2 major systems without involvement of any skin finding. So out of 10 to 20% patient might not presented to you with skin finding, but might have two other system involvement. For example, they will come to you with stridor plus nausea, vomiting. So you know the patient have some form of respiratory involvement and some form of GI involvement. So the skin finding is not, even though it's common, but you might miss it in 10 to 20% of patients. Next. So this is reported in UK Resuscitation Council, where most of the patients who receive vaccination will develop fainting. So the difference between vasovagal fainting and anaphylaxis is the symptom with vasovagal should resolve rapidly on lying flat. But if the rapid recovery does not happen, you need to treat the patient as anaphylaxis. So this is the example of the difference between vasovagal fainting and anaphylaxis. You can see vasovagal, most of the time patient presented to you bradycardia as compared to tachycardia in anaphylaxis, and they have hypotension, similar hypotension, but it tends to be temporary compared to those anaphylaxis who actually become more sustained and sometimes not even respond to the initial treatments of Adenylane, right? So if the patient fainted and it lasted and the symptom is not improved over a period of time, do not hesitate to treat this patient as anaphylaxis. Next. So I know everybody are preparing themselves for vaccinations now. So what should you have? What are the emergency equipment that you need to have for you to prepare or to treat patient with anaphylaxis? So this is basically the equipment that need to cover the airway, the breathing, the circulatory, and also what are the important drugs that you need to prepare. If you manage the patient airway, you need to prepare yourself oxygen delivery devices and intubation kit. Maybe some center need to prepare even up to the level of surgical intubation kit, right? So what about breathing? You need to have pulse oximetry, bed water mask, and nebulizer if you think the patient comes to you. You need to prepare themselves for patient who comes with bronchospasm, for example, right? And most of the patients presented with some form of hypotension or cardiovascular compromise. So cardiac monitor, blood pressure monitoring, crystalloid solution is very, very important. And you need to have defibrillator or AED in your center in certain patients might go into cardiac arrest, right? And the most important drugs that you need to have in all center that actually vaccinate or give, deliver COVID-19 vaccine is Adenylane. That is one important drug that everybody need to have, right? The other drugs that you might want to prepare, it can be a salbutamol for patients with bronchospasm, or extra adjunct therapy such as steroid, antihistamine, glucagon, or vasopressors. So you can have all the list, but whatever it is, you need to cater with your center, and you need to have this as part of the resuscitation, be part of resuscitation of the patients. Next. Then what should you do if you have anaphylaxis patients, right? So first of all, the first thing that you need to do is basically to assess the ABCDE, right? Assess the patient airway, look at the airway patency, look at the breathing adequacy, look at the circulatory adequacy, and have a look at disability, the patient mental status, the patient's conscious level, and have a look at the surrounding of the patient, expose the patient, look, was there any urticaria around the patient's skin, right? And then once you assess the ABCD, establish the diagnosis of anaphylaxis based on the criteria that I mentioned above. And then once the diagnosis has been established, call for help as soon as possible. Get your family medicine specialist, got your emergency physician, get your doctor to come and help, right? And then you can start the initial treatment. Again, after the assessment of airway, look at either if the airway is affected, you need to start giving oxygen, need to open the airway, put the patient in appropriate position, for example, or assess the breathing again, need to treat the breathing inadequacy, see how it goes with, you might want to deliver 15 liter of oxygen through a non-rebreather mask. You might want to intubate the patient as soon as possible if necessary, or have a look at the circulation. Two large IV granula need to be inserted on each side of the arms, and prepare the drugs of Adenylane as soon as possible, and administer the drug as soon as possible. Next. But in certain patients, after the administer of the single dose of IM Adenylane, they might not show any improvement. In these types of patient, you might want to repeat IM Adenylane every 5 minutes, up to 2 doses, and you can deliver IV fluid bolus. Can start with 500 to 1 liter. You can increase and titrate these IV fluids accordingly. And some of the patient will go into what we call as refractory anaphylaxis. What defined as refractory anaphylaxis is if the patient shows lack of response to the equivalent of 2 or more doses of IM Adenylane, this patient can be categorized into refractory anaphylaxis. So what you need to do in this refractory anaphylaxis is basically to repeat IV fluid boluses, and to get expert help to start an IV Adenylane, either slow bolus of infusion, and other refractory therapies. Next. Okay, all the management of A, B, C, D, E, the one that I mentioned just now, must be done in resuscitation area in order to stabilize the patient as soon as possible, right? So the management of airway, as I mentioned just now, look at the airway patency by asking, looking, and listening to the evidence of stridor. If the patient have one, open the airway. If the patient is tolerate to the it's tolerable to be lying flat, you put the patient in recumbent position and to elevate the lower extremities. But in certain patients, for example, patient who comes to you with shortness of breath, you might want to put the patient at 45 degree or whatever position that patient comfortable with. Breathing, for example, all patients with anaphylaxis should receive 15 liter of non-rebreather oxygen. You can deliver, or you can give nebulized bronchodilators, for example salbutamol, or you can give nebulized Adenylane, but whatever nebulizer shouldn't delay the administration of IM Adenylane. Right? Certain patients need to have early intubation. In these types of patients, please think about doing or performing an awake intubation, or because if you delay in doing this, patient can end up with surgical airway, right? What about the circulation? If the circulation is impaired, the patient comes to you with persistent hypotension, low pulse volume, prolonged capillary refill, for example, what you need to do is you need to establish large bore IVs. The smallest size is 16-18 gauge, all right? And then deliver the crystalloid solution, for example, your normal saline, strofandin, or Ringer's lactate as soon as possible. Can start with 500,000 as I mentioned prior, and repeat if indicated. And if the patient goes into cardiac arrest, you need to commence CPR as soon as possible. Then if the patient have a CPR, gather your team and send this patient as soon as possible to the nearest emergency department. Right, if let's say the patient comes to you with seizure or altered conscious level, it goes under the disability of the patient, and make sure you remove all the loosened like tight closures on the patient, and have a look at the presence of urticaria on the skins that we miss. Maybe we miss that's obvious urticaria. So A, B, C, D, E is very important as part of the initial management of the patient who comes to you with anaphylaxis. Next. So have a look at this picture, all right? If the patient comes to you with symptoms of anaphylaxis, for example, stridor, drooling of saliva, IM Adenylane must be given as soon as possible to prevent this problem from happening. If you have an airway obstruction up to this level, the management of airway is very, very, very difficult. A patient can go to hypoxia and goes to cardiac arrest because of this problem. So a rapid assessment of the patient's airway and the preparations for early intubation and anticipate difficult intubation must be done immediately, right? So call the doctors, call the emergency department, prepare the ambulance, put the deliver the IM Adenylane as soon as possible, and send this patient to the hospital as fast as you can, right? What about circulation? If the patient comes to you with hypotension, persistent tachycardia, low pulse volume, for example, next slide please. You can deliver IV fluid to normal saline if you have in your center, or whatever crystalloid that you have in your center. Start off with 500 to 1 liter of fluid as soon as possible. If the patient persistently have hypotension, you can use tools that you have in your department to assess the adequacy of your fluid resuscitation or the fluid responsiveness to the fluid that been given. So you can look at the patient's IVC, you can look at the patient's heart to see either the fluid that been given is adequate for that patient, right? So let us go to the drugs. So as I mentioned, one drug that is very important for you to manage your anaphylaxis is Adenylane. So most all the center that involved with the vaccination should have and should prepare these drugs. So let us go to the first line treatment of anaphylaxis, which is IM Adenylane, right? So how you prepare IM Adenylane? You need to use a pure concentration of IM Adenylane. 1 ampule of IM Adenylane consists of 1 milligram. When we are talking about concentration, is 1 in 1,000 concentration and is equal to 1 ml. So 1 ml equal to 1 milligram of pure 1 in 1,000 concentrations, right? So the dose for adults is 500 mic. 500 mic. You can start with, some of the centers start with 0.3, but I suggest you to start with 500 mic, which is equal to 0.5 ml, right? Let's say your body weight is 70 kilo. If you look at the dose here per kilo, you need to receive 0.7 ml or 0.7 mic, 0.7 milligram. But the limit for the initial IM Adenylane still 500 mic or 0.5 ml. Even in the setting, if the patients already have IV access, the first line treatment is still IM Adenylane. And there is no absolute contraindication of Adenylane in the setting of anaphylaxis. And most patients will respond with a single IM Adenylane if it's given in acute stage before progression to shock. So the faster the delivery of IM Adenylane actually make the symptom better, all right, and it should prevent the patient to go to the severe progression of anaphylaxis. And next, this IM Adenylane should be injected into the mid-outer aspect of the thigh, right? So if you have an obese patient, you might want to use a longer needle to penetrate. Next. I know this group of pediatric are not included in the recent COVID-19 vaccination program, but let's say we open it in the phase 4, for example, you might want look at this or refer to this graph for you to deliver the dose of Adenylane and all other adjunct therapy for pediatric patients. Not so much difference, except the dose are given based on the age and the dose are given based on the body weight. So I'm not going to focus more on this slide. Maybe go to the next slide. Right, as I mentioned, remember I already explained the first line therapy is IM Adenylane, but certain patient will go to it's not respond to the first single IM Adenylane. They might require the second dose or the third dose of IM Adenylane. So to those who have persistent hypotension despite of repeated dose of IM Adenylane, this is known as refractory anaphylaxis. So treatment for this refractory anaphylaxis are, you might want to start patient on epinephrine infusion. You might want to start patient on vasopressor. You might want to deliver glucagon, especially for those patients on beta blocker drugs, and because these types of patient may not respond to epinephrine, and you might want to give patient glucagon before the next epinephrine given. Next. Right. So let's focus a little bit on IV Adenylane. Right. So we already talked about IM Adenylane. Now we go towards this IV Adenylane. Everybody was so afraid to start this IV Adenylane, and you've got two routes of giving this. Either you are giving through IV small, slow boluses, or you might want to start patient straight with IV Adenylane infusion. So based on these studies, they talk about epinephrine in anaphylaxis. Basically, if you start patient with IV Adenylane, it is associated with significantly more dosing errors and cardiovascular complication, and it should be avoided when possible, right? So if it's needed to be given, infusions, continuous slow infusion is preferred compared to a small bolus IV Adenylane, and it must be avoided in infants and children. So try to avoid giving IV infusion Adenylane as soon as avoid giving IV Adenylane in those anaphylactic patients. But if it's necessary to do, make it right. The dose must be right. The indication must be right. You need to dilute the patient using a proper dilution before you deliver the IV Adenylane to the patient. So this is the example of dosage and preparation of IV Adenylane if you need to give this drug to patient with refractory anaphylaxis, right? So if you give slow IV, it must be diluted to 1 in 10,000 solution. What does it mean is, remember just now I mentioned in IM Adenylane is a pure 1 in 1,000 concentration. Now we need to dilute to make it 1 in 10,000 concentration. To get that 1 milligram of Adenylane, syringe out and dilute it, make it a 10 cc with water. So you make it 10 cc and you withdraw 1 ml. So 1 ml is equal to 1 in 10,000 concentrations, right? So if it's infusion, there are lots of ways to prepare IV Adenylane. Certain center dilute 3 milligram Adenylane in 15 ml. Certain center dilute 5 milligram Adenylane in 15 ml. So whatever that you use, you need to know 1 ml is equal to how many mites. So you can refer to the pharmacy. So they most of the time they will come up with a table with the how to dilute the Adenylane and what are the concentration per ml. What are the concentration mite per ml that you need based on the preparation or how much of Adenylane that you dilute in 15 ml, right? Next. Right. So what about the adjunct therapies that we are talking about? I know most of the time management of anaphylaxis, some of the doctors will deliver hydrocort, for example, or will deliver H2 antihistamine to the patients in order to manage anaphylaxis. So this is what we categorize as adjunct therapies, and none of these adjunct therapies should be used as the initial treatment or sole treatment of anaphylaxis. So you have these groups of drug, you have steroid, you have H1 antihistamine, you have H2 antihistamine, and this drug is not recommended as the immediate management of anaphylaxis. But maybe you can deliver it once the problem is settled down, because it took 4 hours to 8 hours for the steroids to work. It took about 1 to 2 hours for the H1 antihistamine and H2 antihistamine to work. So it will delay the management of anaphylaxis. It will cause the anaphylaxis from the less severe symptom to progress to the more severe symptoms. Next. So I know all of you want to come out with an algorithm to to manage this COVID-19 people who actually receive vaccination, COVID-19 vaccination. So I'm suggest for you to follow this algorithm which is published in Resuscitation Council UK. They use this for their vaccination, COVID-19 vaccination program. So it is basically simplified from whatever that I just explained prior. You can use this based on your center. Depend if the center is nearby to the hospital, you can simplify the algorithm more. If the center is a little bit far away from the hospital, you might want to add on more adjunct therapies or up to the level where the patient goes into refractory anaphylaxis. So whatever that you do, the algorithm that you do need to cater from one center to one center. Next. So this is a few last slides of my presentation. The important in managing the anaphylaxis is first, you need to able to recognize the danger signs. Look at the rapid progression of symptoms, the respiratory distress, the persistent abdominal pain, nausea, vomiting, hypotension, dysrhythmias, chest pain, and collapse. Alright, you don't want this patient to go to the severe symptoms of anaphylaxis or goes to hypoxia and cardiac arrest. Right. So CDC suggests for all patients who receive COVID-19 vaccination, they should at least be monitored for 15 minutes post injection. And for those who actually have a history of certain allergic reaction, they should be monitored a little bit longer, up to 30 minutes. So this is what been recommended by the CDC. But I think Malaysia Ministry of Health also come up with the guidelines similar minutes of monitoring for all patients with who actually receive a COVID-19 vaccination. Next. Again, as a summary, these are 3 steps which is very, very important. Number 1, assess ABCDE, manage your ABCDE, and administer IM Adenylane as soon as possible. That is the immediate life-threatening management for anaphylaxis. Then contact the doctor to come and attend the patient. Contact your family medicine specialist, contact your emergency physician, or call 999 to transfer this patient as soon as possible to the hospital. And even though the patient is improving after the administration of IM Adenylane, transfer is very, very important because you need to monitor the progression of the disease and you need to look for the development of the delayed reaction. This is the one that we worried of when the patient comes to you with biphasic phase. Most of the time, it can occur after 24 hours post initial phase has been resolved. So whatever that you do, even the patients improve with the first initial IM Adenylane or with your second or third IM Adenylane, that patient need to be transferred to a higher level of medical care. So I think that is basically the wrap up for my presentation this morning. So I open for a question and answer.
Thank you for the presentation. I think we are all enlightened about how to recognize anaphylaxis and also how to manage it properly. Yeah. So shall we take some questions, Dr. Azma?
I think so. I can allow a few questions.
All right. Okay. Dr. Azma said she can allow a few questions. Right. Anyone would like to ask anything? Don't mute anything. Okay, we can unmute the participants. anyone would like to ask burning question to Dr. Azma? This is a really great opportunity for anyone who has any questions, yeah? Any doubt? Please.
Assalamualaikum and good morning.
Yes, Waalaikumsalam. Good morning.
Yeah, I'm Dr. Asika from PKD Gulangat Selangor. First of all, thank you very much for the very good presentation, Dr. Azma. I just want to ask, because we are in the process of planning for vaccination for our first frontliner, first phase lah. So I want to ask, because some of the plan is to do outsource vaccination, where we go to the site and do vaccination at the site. So is it actually advisable, since I heard one of the side effect will be anaphylaxis, so is it actually advisable for us to do that kind of plan? I mean, go to the to the site, like for example, we do at the day one, or we go to the police area to do the vaccination. Is it actually possible to do that? Thank you.
Okay, I will go back to my presentation. As I said, or whatever that you want to do with the vaccination, where exactly is the area that you want to vaccinate the patient, that the equipment to resuscitate the patient must be there, right? If you're able to bring the resuscitation team or the equipment to the site, you can let's say if the patient develop anaphylaxis and you can manage the patient at the site, I think it is feasible. But if it can't be done, or if the area is far away from the hospital, most likely you want to delay from doing that. You might want to, maybe in the later stage, when more data has come up with this COVID-19 vaccination anaphylaxis, so maybe that can be done. But I think at this current time, maybe more preparation for anaphylaxis must be prepared for those patients. Resuscitation must be done at the more control area. So I think should do the vaccination in the designated place rather than go to the site.
I have a question.
Yes.
I'm Dr. Gan. You were talking about giving the dose of adrenaline, and I couldn't get what you mean by how many mics per meal. What does that mean? The mic.
All right. Okay. Because certain center they prepared IV adrenaline dilution. All right. If they prepare the infusion, some of them prepare 3 milligram of IV adrenaline, 3 milligram of adrenaline into 50 cc. They make it 50 cc. So the concentration will be differ for those who actually prepared 5 milligram of adrenaline into 50 cc 50 cc syringe. The whatever that you do, the concentration is different based on the amount of adrenaline that been diluted. So you need to really know how much of adrenaline that been diluted and how much of per mic of adrenaline in 1 ml of solution that you prepare.
Sorry, the mic. What does that mean, mic?
That is actually the concentration of adrenaline that you prepare.
Means how many? Mic mean refer to what, milligram, microgram, or something?
Microgram. That is microgram.
Microgram. Okay, thank you.
Yes.
Hello, Doctor.
Yes.
My name is Dr. Nadia from PKD Perak Tengah. So my question is, referring to your last final slide, you did mention about biphasic reaction. So giving an example of a case lah, if let's say within 15 minutes patient develop mild reaction, it's just skin rashes, not yet up to respi or cardiovascular system lah. So that kind of patients, let's say actually we observe and patient so is in that kind of patient, is there any do we proceed giving with IM adrenaline? Because
I'm so sorry, I can't hear the.
Hello?
I'm so sorry, I can't hear really. The question is kind of interrupted. Maybe the line is not so good. Yes, can you repeat again the question, please?
Okay, I try again. Doctor here, is it clear?
Yes.
This.
Yeah, now it's a little bit okay.
Okay. Is in a example of a condition where patient just develop mild reaction like skin rashes or like urticaria, but not yet up to cardiovascular or respi symptoms. So that moment, do we straight away give IM adrenaline because of the concern of developing of the biphasic more severe reaction afterwards? And do we transfer the patient to the hospital then?
All right, okay. You need to go back to the definition of anaphylaxis. To define anaphylaxis, the patient need to develop sudden onset or acute onset of either skin reaction plus other system. For example, if patients come to you with hypertension or the patients come to you with airway compromise. So that is number one. Right, if the patient's only presented with pruritus, it can be just an allergic reaction. It's not yet anaphylaxis. It's allergic reaction. In allergic reaction, IM adrenaline is not indicated. Right? So in allergic reaction, that patient need to be monitored. Of course, it need to be monitored because of this biphasic reaction. You can, if you don't have area to monitor the patient, you can send it to the hospital because sometimes even here in emergency department also we monitor those patients with allergic reaction only for 6 to 8 hours. After 6 hours, if the symptoms improve with the management, with the adjunct therapy, so we discharge the patient.
I see. Yeah, thank you, doctor.
Okay.
Hello. Hi.
Yes.
Hello.
Hello. Hi. Yes.
I'm Dr. Faiz speaking.
Yeah.
Okay, I'm from Hospital KKB. I have a question. For patients who have history of mild or moderate allergy reactions to any kind of allergen, and is it advisable or is there any test saying that taking prednisolone prior to taking vaccination could actually reduce the onset of any kind of allergy? Is it advisable for them to take prednisolone prior to that, or patients who have asthma to take MDI, salbutamol, MDI, Symbicort, for example, prior to that, prior to vaccination? Thank you.
I love these questions. Okay, this has been addressed by CDC. If those patients who has some form of allergic reactions prior, so you are not advised to take antihistamine. You are not advised to take nebulizer prior to the vaccination. The reason why, because all these antihistamines can mask the effect of anaphylaxis or the symptoms, signs and symptoms of anaphylaxis, and it does not confer any benefit in the management of any anaphylaxis, in the management of angioedema or anaphylaxis. So please, those patients who have a certain history, do not advise them to take antihistamine or to take nebulizer prior to the vaccination program. Does it answer your question?
Yeah, thank you so much.
Hello, Dr. Azma.
Good morning, Dr. Azma. This is Ketan from Hospital Tambunan. I would just like to ask regarding the nebulization. Is there any role or any superiority for nebulized adrenaline compared to nebulized salbutamol in anaphylaxis? Thank you, doctor.
Right. Yes. It is recommendation saying that you can deliver a nebulizer adrenaline for those patients who comes to you with bronchospasm, right? So, but whatever nebulizer adrenaline that you want to give is, you shouldn't prioritize it prior to the administration of IM adrenaline. So whatever it is, if the patient comes to you bronchospasm, IM adrenaline first. If by IM adrenaline the symptoms is not improved, then you can consider giving nebulized adrenaline, but it shouldn't take over the administration of IM adrenaline in initial stage. So that is the recommendation. Even in UK also, it said give IM adrenaline, not respond, then you can start thinking to give nebulized adrenaline. So it's not the priority in the management of anaphylaxis or in the patient who come to you with bronchospasm.
I'm Dr. Muzamil here. Dr. Azma, can you hear me? Hello, Dr. Azma?
It's kind of little bit little bit interrupted. Maybe hello. Yes.
Hello? All right. Okay, I have some questions from YouTube Live. There's a few participants asking about various level of allergic reactions to other allergens. Is it safe to receive the vaccination? They have varies of severe reaction, which is some of the questions saying that having a history of anaphylaxis and intubation prior to this with other allergen. Is it safe to receive the vaccine? And also some with the question of having history of urticaria SOB after influenza injection, and is it safe to have the vaccine?
All right. Okay. I will answer this because a different guideline gave a different country come up with different guideline on contraindication to give COVID-19 vaccine. UK gave a different guideline. CDC gave a different guideline. Even Malaysia come up with our own guideline. Singapore come up with their own guideline. So based on CDC, I will respond based on CDC first. Based on CDC, those patients who shouldn't receive vaccination or COVID-19 vaccination is a patient who have severe reaction or allergic anaphylactic reaction to the mRNA vaccine, all right, to the mRNA vaccine, also to the content of the vaccine. For example, the polyethylene glycol or polysorbate, if they have prior reaction to these three, they should be contraindicate from taking the COVID-19 vaccination. All right. If they have allergy to influenza vaccine, for example, if they have allergy to influenza vaccine, they said this is not an absolute contraindication, but it is a relative contraindication. You might want to delay the patient. You might want to counsel the patient about the sign and symptoms of anaphylactic reaction in these types of patients. So I might not. The only three things that actually against COVID-19 vaccine is those patients who have severe anaphylactic reactions to the mRNA vaccines prior. All right. Number two, to the content, which is the polyethylene glycol and polysorbates, and also those, even in those who actually receive vaccine and they do not know what are the ingredient or the component of the vaccine that lead to the allergy, this is also under the relative contraindication. It's not absolute contraindication, right? So that is my answer. But guideline is guidelines. Malaysia come out with the guidelines saying that those patients who has a history of severe anaphylactic should be avoid or should be not given any COVID-19 vaccine, or Singapore guidelines saying that those patients who have some form of Stephen Johnson syndrome, for example, or thermal necrotic epidermolysis, they also shouldn't receive COVID-19. So whatever it is, I think Malaysia's come up with a guideline saying that those who have a history of severe anaphylaxis shouldn't receive COVID-19, or those who have a severe allergic reaction or anaphylactic to mRNA vaccine or to the content of mRNA vaccine, or the content of vaccine that have a specific components of polyethylene glycol or polysorbate, should avoid from taking this COVID-19 vaccine. So I think this answer your questions.
Yeah, I'm Dr. Gan. Regarding the polyethylene glycol, actually there are quite a number of oral medicine. For example, paracetamol has polyethylene glycol. So if somebody has got allergy to, let's say, Panadol, would that be a danger for them to have the mRNA vaccine?
Right. Okay. If it's already proven that they have anaphylactic reaction to that content, so you might want to avoid of giving this COVID vaccine-19. But the certain condition, for example, if the patient benefit is greater to the risk, I think it is safe if you are giving the COVID-19 with some form of counseling with the referral prior to the allergies or to the doctors to talk about this sign and symptoms of anaphylaxis in these types of patients. Even CDC come out saying that those patients who have any form of allergic reaction must be discussed prior to the allergies if they insist of taking COVID-19 vaccination, number one, and those patients from a special group such as from the frontliner because the risk is higher in getting COVID-19 compared to the risk of anaphylaxis. So these types of patients must receive COVID-19 vaccination.
I just want to add on. Malaysia, Ministry of Health is going to come up with our own guideline on the contraindication, for COVID-19 vaccine. It will be out very, very soon, I believe. Yeah. Okay. Another thing, with regards to the question, when we want to do a mass vaccination outside, as what Dr. Azma mentioned, we need a backup in terms of managing anaphylaxis in case it happens. Yeah, so at least the basic management can be done. Yeah. Thank you. Any shall we take more question, Dr. Azma or
Dr. Azma? Can I ask one question, Dr. Azma?
Right. Okay.
Dr. Siti from Klinik Melima. Looking back at your diagnostic criteria for anaphylaxis, number 2, either A, B, C, D, if the patient presented with, let's say A, involvement of skin, mucosal tissue, and D, persistent gastrointestinal symptoms, can we give IM Adenylane without respiratory compromise or reduced BP? 2 out of 4 possibly anaphylaxis, or this actually most likely anaphylaxis, but the respiratory and the BP is still intact. Can we give IM if the patient presented with these 2 organs?
Yes, if it is based on the presentation prior, one of the different. Can you hear me?
Yes. Yes, doctor.
Can you? Okay, all right. So if based on the second diagnostic criteria that I mentioned prior, if you have 2 system involvement, you can diagnose this patient as anaphylaxis. Either the patient comes to you with GI plus neurovascular, or the patient comes to you with GI with respi, that you can treat this patient as anaphylaxis. Basically, even in certain patients, even it does not fulfill, as I mentioned, it does not fulfill the criteria, but the patient have history of severe anaphylaxis prior, and that patient only comes to you with severe urticaria opritis with no involvement of cardiovascular, no involvement of neurology, no involvement of GI, you can treat that patient as anaphylaxis. If the patient has a prior history of anaphylaxis, right? So it is basically a clinical diagnosis, right? It's not only focused on low BP hypotension. It's just to make it easy. It's just to make it easy. If you have skin involvement plus respiratory and hypotension, then it is make it more likely to have anaphylaxis if you follow the Sampson's criteria. But it can also develop purely just a severe generalized urticaria or pruritus in patients who have a severe history of anaphylaxis prior. So to answer the question, is it indicated to give IM adrenaline? Yes. If the patient already have two systems, yes, you can deliver IM adrenaline.
Thank you. Okay, any more question before we close the session?
Ada soalan dekat chat box.
Right, we have few questions at the chat box, Dr. Azma. Boleh bacakan?
Yeah.
Boleh baca.
Dr. Azma, one is the question is, if a patient with fainting post-vaccination is mistakenly diagnosed with anaphylaxis, will the IM adrenaline injection pose risk of cardiac arrest for the patient?
Alright. If you administer IM even in anaphylaxis, the risk is there. Even in those patients with anaphylaxis, the risk is there. Right? So what you need to do if you mistakenly administer IM adrenaline for those vasovagal patients, the monitoring is mandatory. You need to have a continuous cardiac monitoring. You need to have a continuous blood pressure monitoring, and you need to send this patient to the hospital for proper monitoring and resuscitation. So it's not only, that's why I said even in anaphylaxis, even the patient improve with IM adrenaline, that patient need to be transferred to the higher center for the monitoring. It's just to look for the side effect of adrenaline if let's say they occurred during that time or after that. Does it answer the question? I hope it's answered the question.
And another question, doctor. Since hypotension is a sign of anaphylaxis, shall we monitor the BP before and after vaccination?
Yeah, I got this question in my first session. All right. Okay, I will answer again. If the patients come to your center and the number of patients is small, yes, it is good to have a monitoring of BP before and after vaccination. All right. But we are talking about 100, 2,000, 3,000 or million of patients who come to the vaccination center. In that condition, I don't think it is feasible to monitor the blood pressure. All right. So what we need to do is, if the patients come to us with a symptoms, let's say after vaccination they develop a symptom, then I think it is good for you to monitor the blood pressure. If the patient is okay, can play with the phone, no symptom at all, I think it's not mandatory to monitor the blood pressure in these types of patients. So it depends on the center. If you only receiving one or two patients, you can do BP before and after vaccination. But if you in the center where you giving 1,000 of vaccination per day, I think it's not feasible to monitor every single patient pre and post vaccination. So I hope this answers the question.
Thank you, doctor. And another question is, what kind of bleeding disorder yang kita not recommended for them to tak boleh ambil vaksin, kata dia, ayat dia.
Tak boleh. I think I will answer. I also not so familiar with what types of bleeding disorder that you shouldn't take the vaccine. I think not so much bleeding disorder that you can take. Maybe need to refer this question to Dr. Noraisha to answer these questions.
Macam yang Pfizer.
I don't think so. They got certain patient with bleeding disorder who cannot take COVID-19 vaccination. Not really a contraindication.
Right. I think to be safe, I think we all need to refer to the guideline that is going to be out very soon from Ministry of Health. Yeah, that actually explain details on the indication and contraindication. Yeah. And another question, doctor. In the event of sudden fitting or seizure following the vaccination, should we administer Valium first or Adrenaline first?
Put the patient left lateral, and then you can give the adjunct therapy with treatment of fitting. So left lateral fitting, put the patient left lateral, IM adrenaline to the patient, and then you can to this patient if the patient insists. Most of the fitting will stop less than 2 minutes, right? So by putting the patient on left lateral, you are reducing the risk of aspiration. The treatment, if it's anaphylaxis, the treatment, life-threatening treatment is still IM adrenaline. If after that more than the fitting is persisted after 2 minutes, then the IV Valium can be given.
Okay, thank you, Dr. Azma. I think this is the last question. Can anaphylaxis be diagnosed if has history of severe anaphylaxis and one GI symptom after COVID vaccination?
Okay, I think this is the question that one of the participants asked just now. If, let's say, the patient have severe anaphylaxis prior and only come with one symptom of pruritus or one symptoms of GI, yes, you can treat this patient and you can give IM adrenaline in these types of patient, because again, I say again, it is a clinical diagnosis. If you have a highly suspicion and this patient have a very bad anaphylactic prior, with history of prior anaphylaxis, then even with one manifestation, you can give IM adrenaline.
Dr. Azma, Dr. Azma, shall we close the session? Any last message from you?
If you're not sure, okay, actually I have algorithm that I set up with PKD Kinta to be used for the vaccination center here in Ipoh. So if you want, we can share and we can share and you can get it from me. But the thing is, whatever it is that you want to do, you can change it based on the center that you are working, based the drugs that you need to prepare based on the center. Is it near to the hospital or is it far from the hospital? So if you want to get the slide, if you want to get the algorithm, I can share with you, but whatever it is should be tailored to the center that you are working with. So if you are not sure, the next thing is to call your FMS early, to call the emergency physician early, to call the doctors early for you to manage patient with anaphylaxis. That is my last note. Thank you very much.
Right. Okay. Great. Thank you so much, Dr. Azma Haryaty. She has actually explained within 1 hour all the essential things related to anaphylaxis. Yeah, how to identify the occurrence of anaphylaxis, the clinical manifestation, the equipment, the medication needed, the A, B, C, D, E. Yeah. And then the details of IM adrenaline, the dose, and other adjunct management as well, yeah, and the do's and don'ts in anaphylaxis management, yeah. So we also have a very fruitful discussion related to this matter, yeah. So I think if Dr. Azma allows, maybe we can share whatever material that she has produced with the others lah, and it like what she said, it need to be customized based on our facility setup, yeah. Right. Okay. Just to because so many people actually asked me about the slides. I think Dr. Azma said that I asked that previously. I think she allows us to share the slides. So we'll try to see what we can do lah. Yeah, where we're going to upload the slides. But please bear in mind please acknowledge the person who actually produced the slide, which is Dr. Azma herself lah, yeah, right. And also we managed to record this session and we're going to upload it in YouTube, yeah. So